Thank you very much. As we're putting up my slides, I just want to thank SAGES for the response. And we talked about it ad nauseum a little bit, and you heard about it this morning. But really, those emails that Dr. Dort was talking about, I was honored to be included, but it seemed like I was always behind. So I would add my 2 cents in and make sure we weren't getting out late. It was really pretty impressive the way it worked. So I'm going to talk about critical care and from the pandemic, what we've learned. Where's my, there, sorry. I have no disclosures. I'm sorry, I do have one disclosure. It's up to date. It has no relevance to this talk. And while we're focusing on the pandemic at hand, which is the COVID-19, it really applies to any pandemic or any situation. It may happen again. It may be a different variant. It may be a whole new virus, or maybe something else. Who knows? But I think surgeons are pretty well equipped to handle these disasters or these pandemics. The lessons that I learned as it relates to critical care: number 1, allocate your resources. Number 2, remember your critical care days. So it's still a requirement from the American Board of Surgery for any surgeon to know critical care. There are questions on it every year. During the mock oral sections, my residents do particularly poorly on critical care. I was a little disappointed about that, but it's in their education. They should know it. Remember your protocols, and not every hospital has one, but you should go by it so you don't forget things, because it can be pretty crazy. And last but not least, focus on the people who are helping you care for these patients. A pandemic, I consider it like a mass cal, as Dr. Pryor's alluded to. I'm a military member, so we're very well versed in mass cals. But very simply, is the number of patients exceeds your resources, and that can be a lot of patients, like in this image from the Boston bombing, where hundreds of people were injured, and very quickly the local first aid people were very overwhelmed. Or it can just be a couple patients. So this is my surgical team in Iraq, and we had about 10 people. We had only 2 patients, but they were both critically ill. And it really quickly overwhelmed our resources, even though it was only 2 patients. So it doesn't really matter what situation you're in. If you have more patients than you are really prepared to care for, it becomes a mass cal. But there are some good lessons that have been learned recently from other events. So one of them is that not all the patients can go to one institution. If every patient in Las Vegas, and remembering that great tragedy here, all went to the same hospital, then that hospital would be crushed. And they had a plan, though, and some went to the other 2 hospitals that are immediately available, but some went 20 to 30 minutes away to hospitals that were considered community hospitals, and there was good triage in there. And in that regard, the people who did survive the initial shooting actually did pretty well, and not any one hospital was overwhelmed with patients. The same thing actually happened in the Boston Marathon, so it's kind of funny. All the Harvard hospitals, like to say they're better than the other Harvard hospital, but it was very clear that 10 were going to go here, 10 were going to go here, 10 were going to here, and we're going to divvy up between Tufts and BU and BC and all those other hospitals there, because if those hundreds of patients went to Mass General, as great as they might be, they would not be able to handle those hundreds of patients all at the same time. In Oklahoma, they actually did pretty good with the system. There's 4 main hospital systems in Oklahoma, and they don't like to play with each other, but individually they had pretty good satellite clinics they utilized, but they actually came together pretty quickly and said, hey, we're running out of beds and ventilators, so who's open? Let's work together on this. And that comes from the communication. So you first have to allocate your resources when you're talking about providing critical care. And what research are we talking about? Well, first of all, the personnel. So obviously, if you have intensivists, they need to be utilized. And anesthesiologists, of course, can intubate people, and they can run ventilators. They do that every day. Pulmonologists and cardiologists, they typically will cover ICUs, and so they're available for it. Your emergency medicine physicians are also very facile at both intubating and running ventilators. And we should include ourselves, general surgeons, as being able to do that. Again, it is one of our critical core competencies. Now, we might be breast surgeons later on, or those of us who do foregut, and our patients leave the hospital after 1 day and have very minimal pulmonary complications because we're no longer doing open surgeries. We may not feel that we're having to use those skills, but they're there somewhere. And I was telling a friend of mine when we were deployed one time, this is if we have a complex retroperitoneal hepatic injury, I'm not a HPB surgeon. And I said, well, you're the best one right now that we have in country. So, open your book, review it. You're never going to feel comfortable. So even if you did, hundreds of these, because it's a very dangerous injury. So you should feel comfortable that you are okay to do some of these skills. So this is the primer on mechanical assistance, and we talked about this in one of the seminars, but basically there's two big modes. There's continuous mechanical ventilation, which means every time the machine breathes every time, gives the same rate and volume and FiO2 to the patient every time. There's a couple of different modes that go along with that. In the assist control mode, the continuous mechanical ventilation occurs with a set amount of volume pressure every single time. It can be volume controlled, meaning it's a preset volume, 500 cc's or whatever it might be for the patient, or it can be pressure controlled, meaning that the volume is given until a certain pressure is reached, and that resultant volume is at the volume the patient gets. And there are different reasons to do those types of things. There's also pressure support ventilation, which these are just like your CPAP and your BiPAP, meaning they just need a little assistance. They're not having a problem with FiO2, they're just having a problem getting the air into there and keeping those alveoli open. Intubation. So we shouldn't forget about this. This may be a little scary to general surgeons, even though we sort of take part in intubations every day if we come in the operating room. In the military, we make it simple for our providers. We try to dumb it down. So we only really learn for combat and the rapid sequence intubation. Probably the most important thing is to prepare. So just like you're doing a central line, make sure the oxygen is nearby, your mask is nearby, the intubation, the laryngoscope is nearby, your stethoscope, because you don't want to be reaching for these things as you're trying to do this. Prepare, have everything at arm's length away. Etomidate, 1. If you forget the dosage, is 1. Sucks, also 1. Don't forget the dosage. I know there are some contraindications to using succinylcholine. Likely your patients will have a chemistry to know what the K is, but in an emergency situation, you're not going to wait for that K to come back. If they need to be intubated, they need to be intubated. Cricoid puncture is a very important rapid sequence intubation. Do not let your helper let go of the cricoid until you're sure that tube is in. And how do you make sure? The gold standard is end-tidal CO2. So even if you watch it go past the vocal cords and you hear breath sounds on both sides, the gold standard is end-tidal CO2. How do you, now once you get them intubated, what are you focusing on? Well, SARS, the COVID-19 disease, is mostly a disease of poor oxygenation, meaning that you're not getting enough oxygen into the blood. So the two ways to increase that are increasing your PEEP and increasing the FiO2. And that the PEEP just improves the exchange. The FiO2, of course, is the amount of oxygen that's actually getting to the patient. Start at 100%. There's no reason to say, this patient's not too bad, I'm going to give them 60%. And start at 100% and work your way down. Use your ABGs to decide how well they're doing. If they're a COPDer, you can live with a saturation of 88%. I obviously like it to be better, but 88% is not so bad. Ideally, you'd work it all the way down to less than 60% and decrease from there to get the patients hopefully extubated at one point. Positive N, you usually start around 5. You may have to have it higher for obese patients. But the bottom line is, again, you increase it as needed to make sure your saturation and make sure your PaO2 is adequate. I'm going to skip past this. This is just something that, and this is about the ventilations, which we don't typically need to worry about as much. All right, so then your tidal volume, you will need to keep an eye on it after a while, whether you set it or you have it resultant from your pressure control ventilation, because at higher volumes, you tend to have more ARDS and more problems with your patients, and they won't be able to get off the ventilator. All right, so let me skip ahead. You see the numbers that you need for pressure control and volume control ventilation and the reduction of barotrauma. And last thing is, once you get them intubated and get their oxygen up, there are other issues that you have to be aware of. Now, this is obviously a no-brainer for any general surgeon. Nice pneumothorax, you put a tube in, taking care of it. Do not forget the fact that these patients probably need anticoagulation, and whatever procedure you do, you have to adjust that anticoagulation before you do it. And then whatever hospital you're at, I talked about protocols before. There are different kind of medications out there for patients who are not responsive to intubation or steroids. These are all under trial at my hospital. It's actually, I was surprised to see that they had 5 different protocols, but they do. Actually, and as a provider, I actually don't know which one they're using. It just says protocol drug. So when we have complications, then we have to go back and say, hey, what's the deal? Lastly, and I know I'm over time, but you have to be mindful of provider fatigue. There's the physical part. These tend to be long shifts. It's a pain to put on PPE over and over again. In some of the most extreme cases, they're away from their families. Communication, as you saw, Dr. People have been taking off their masks in order to talk. It's hard. When you're all masked up, ventilators are running, it's hard to hear. But the psychological fatigue is probably worse, right? In Oklahoma, we were 40% vaccinated in July, and I was very disappointed, since 99% of the patients in the hospital were unvaccinated. It was tough sometimes to take care of them. Now, I would kick the door or whatever, and then after 5 minutes I'd overcome it, but it's still tough to realize you're taking somebody who's unvaccinated and it could have been prevented. Working outside your comfort zone, as I said, you have to do it, but it does take a toll on you. And being full capacity, wearing these goggles, wearing your masks every time you go somewhere and do something does wear on you after a while. So these things, you have to be able to take care of your people who work around you, yourselves. I work with residents. At one point, 43% of our residents were out with COVID, either the disease or a close injury, and that people had to cover down, so they were getting worked and tired. And you can't forget those patients, those people when you're taking these patients. All right, I know I went over time and I apologize, but know your assets, remember your critical care, it's within all of you, I promise you. And then, of course, take care of your fellow workers. Thank you very much.